Hello. Today we are covering blood vessels. So let me share my document with you. And let me put in slideshow mode. Excuse me. These are your notes that you find on the course page. Okay, so circulation. We're going to talk about vessel walls, their different layers and tissues and their functions, and some circulatory patterns. Blood vessel wall anatomy is composed of 3 layers. You have the internal layer that's intimate with the blood itself as it passes through the vessel. That's called the tunica interna. It's composed of simple squamous epithelium, and those squamous cells that are very flat, like a fried egg, help reduce friction as blood passes through it. And thus it reduces what's called resistance. Resistance is anything that opposes blood flow. The tunica media, the middle layer, is composed of smooth muscle. That's our contractile layer, is capable in certain vessels of vasoconstriction and dilation, but it can certainly constrict and relax to a certain extent. And then we had the tunica externa, the connective tissue that secures lymphatic vessels and nerves to that structure and holds the vessel in place. All right, so here we see pictures of an artery on the right and a vein on the left. And there you can actually, by just looking at these pictures, is to be able to compare and contrast to a certain extent an artery versus a vein, which, comes up later. So over to the right, arteries, they have a very thick or thicker tunica media. So if you see here where this smooth muscle layer is, it's going to be thicker in an artery than it is in a vein. And the lumen, the size of the passageway, of blood in the interior of the artery is going to be narrower compared to a vein. So the arteries are designed to withstand more pressure because it's trying to propel in a forward direction the blood that's being ejected from the left ventricle. And then as blood passes from the artery to an arterial to a capillary bed here in the center, it's going to branch off into very fine vessels that have the diameter about 1 red blood cell at a time. So, excuse me, I've got a little bit of a cold, pardon me. The blood is going to enter oxygenated on the arterial side. The capillaries spread out thin enough for 1 red blood cell to pass through it at a time. It will allow diffusion of gases, and different nutrients from the blood into the interstitial spaces. And then as it recollects on the other side, it becomes blue because now carbon dioxide is now diffused into the blood, and we've dropped off a significant amount of the oxygen that we're transporting. And those venous capillaries are going to merge to form venules to veins and then travel back to the right side of the heart, to the right atrium. So now let's look at the vein. It has a much larger lumen, than an artery does. The tunica media is much thinner, and veins have valves to prevent backflow, just like in the heart. Okay, so the vessel types, we have arteries. Basic definitions: arteries transport blood away from the heart. Capillaries is that branching network we just looked at. That's a site of gas exchange, nutrient, and waste diffusion. And veins transport blood back to the heart. Okay, here histologically, you can see a real difference too. Arteries, they generally are going to have, or they always have, a thicker tunica media. Sometimes they're collapsed like this, but frequently in other organs, you'll see them popped open because there's still a good amount of blood in the lumen when the specimen was obtained. So frequently it'll look like a tire or a donut. Everything reminds me of food. And you can see there's respective layers. The most internal layer that kind of looks like this convolutions here. Or if you remember ribbon candy that you used to have like years ago in the 60s and the 50s, it was loopity-doopity like that, a ribbon. So that would be your tunica interna. The smooth muscle here is your tunica media, and the outer connective tissue layer is your tunica externa. Over to the lower right is your vein. Veins will collapse frequently, even if they have a significant amount of blood in it, because the tunica media, the muscular layer, is not significant enough to keep it, patent. That's what we call patent. But you can see the three layers. The most internal layer that would be intimate with the blood. And the blood, you can see all that granular kind of tissue. The red granular tissue in there, that's the blood, or some of the blood. Tunica interna, tunica media, tunica externa. Okay, so arteries, all but pulmonary arteries carry oxygenated blood. So, when you're looking at models and things, you say, oh, arteries are red and veins are blue. And to the most part, that is true. But there are two areas in the body where that rule is not going to apply. Pulmonary circulation, when we looked at the pulmonary trunk and the pulmonary arteries that transport blood away from the right ventricle, so they're an artery, but they're still blue, they're still carbon dioxide rich. And the veins that transport blood back from the lungs to the left atrium are going to be red because they're transporting oxygenated blood back to the heart. Now, also, when it comes to fetal development, the blood supply to and from the fetus, from the placenta, is also going to be opposite like this. I'll just tell you. But anyways, we'll look at that more, when it comes to development. All right, so arteries, we have elastic arteries that are large, have thick tunica medias. They're the ones closest to the heart that expand and recoil in response to ventricular contractions and act as a pressure reservoir. So what their job is as we're ejecting blood from the left ventricle, as you know, into the aorta, out into systemic circulation, and actually to coronary circulation as well, is that those elastic arteries are designed to expand to accommodate that stroke volume of blood that's coming from the left ventricle, but it's supposed to just kind of recoil, kind of like a rubber bandish, and keep the pressure in the vessel so that the artery doesn't expand too much, and then you lose some of that pressure. We want it to kind of bounce back some and keep pushing that blood forward because it has to go all the way out, to capillary beds and start heading back again. So they are neither the elastic or the muscular arteries really going to have any significant impact on blood pressure because they don't have significant vasoconstriction. I mean, they can constrict because they have to be able to recoil and bounce back, but it's not going to have a big impact on blood pressure, such as arterial as well. Muscular arteries deliver blood to the specific body organs. They have a thinner tunica media than a lot of those elastic arteries. I need to close that parentheses there after arteries. My apologies. And then we have the arterioles. Now the arterioles become much smaller and they have the same, 3 layers to it, but because they are narrower and they're accommodating kind of less blood in each of the arterioles, and they lead to the capillary beds, is that they are capable of significant vasoconstriction and dilation. Primarily controlled by the sympathetic nervous system. That's our sympathetic tone we talked about in the autonomic nervous system. Therefore, they heavily influence blood pressure. When you vasoconstrict, you increase blood pressure. When you vasodilate, you decrease blood pressure. Capillaries, are a single layer of essentially tunica interna. It's composed of simple squamous epithelium with a little bit of connective tissue around it. And that's to allow gases and nutrients and waste products as necessary to either diffuse from the blood out into the tissues or from the tissues and interstitial spaces back into the blood. So you have to have a thin wall so that material can diffuse. The same thing will happen at the respiratory membrane, in your lungs. You have to have like 2 capillary beds coming together so that you have these little fenestrations between the squamous cells because, they're somewhat tightly packed together, but, because they're not cuboidal and columnar with those flatter surfaces, you're going to have slight little open windows, I call them. And so which allows molecules to diffuse. It also allows those white blood cells to, squeeze out and diapedetically leave the blood and chase down bacteria. They form interweaving networks called capillary beds. and between connecting the arteriole to the capillary are what are called precapillary sphincters. So sphincters are like any other sphincter, kind of like orbicularis oris is a type of a sphincter, I guess you could say, that can contract and close your mouth and purse your lips, or it can relax and you can open your mouth. So sphincters can contract and relax. And they're circular, that go around the entire circumference, of the vessel. Regulates blood flow from the arterial supply into the capillary. Thus, it will act to help control blood pressure along with the arterioles to help either vasoconstrict or dilate. They do this so by constricting or dilating their diameter and regulate how much blood enters the capillary bed and how much blood backs up. So if we want to increase blood pressure or need to increase blood pressure, the arterioles will contract and so will the sphincters. It's going to limit the amount of blood entering in the capillary, which causes everything to back up behind it. And thus that blood exerts more pressure against the vessel wall, and thus it increases blood pressure. Right? Capillaries are semi-permeable to allow diffusion. And hydrostatic pressure is due to the contraction of the left ventricle, or as the left ventricle contracts, it forces molecules that can pass between the squamous cells into the interstitial spaces. So what do I mean by that? I use the example of a hose, right? Like a garden hose outside your house. And when you open up the valve and water rushes into the hose, the water pump is pushing the water, right? And if you have a nozzle at the end of the hose, and you're not squeezing the nozzle, the water all backs up into the hose and is pushing against the end of the hose where the nozzle is. But unless you squeeze the nozzle and let the water come out, is that, the pressure is going to be building up behind it. When I squeeze the nozzle, water spurts out, right? And that's because of the pump behind it. So when you're pumping blood like this and you enter areas like capillaries that have squamous cell tissue there, or squamous cells, it allows those molecules to get pushed out. And anybody that's of the appropriate size to get through that little window can be pushed out. Now, generally, your formed elements are going to stay in because we want to keep your red blood cells and most of your white blood cells, unless there's indication of infection, in the blood, and your albumin that maintains that osmotic gradient. So the hydrostatic pressure is kind of that push outward in this case, and the osmotic pressure is going to be the pressure, created by the blood in the capillary as it loses a lot of the water, component parts of plasma, which is, the 55% plasma, about 92% is water, is that as the blood passes from the arterial side to the venous side, it now starts to act kind of like a hypertonic solution. So then it has a tendency to draw fluid back into the vessel on the venous side, and allows all the carbon dioxide to come in, whatever needs to be diffused and transported. Right. So we lose some water on one side, the arterial side of the capillary, because of the hydrostatic pressure, but then we draw fluid back in, and that keeps fluid moving. Now, not all the water we lost to the hydrostatic pressure will necessarily be sucked back in, so it remains in that interstitial space. The job of the lymphatic system at that point is going to be to kind of suck up the rest of that fluid there into the lymphatic vessels, the capillaries, ultimately to lymphatic vessels, and it will be transported through different lymph nodes, ultimately back up to the chest, to the subclavian veins, to act to restore blood volume. As that lymphatic fluid passes through the lymph nodes, that you're also going to monitor it for infection, for any kind of microbes, but ultimately it keeps moving that interstitial fluid. Either the fluid will be drawn back into the capillary osmotically, or it will be kind of sucked up into the lymphatic capillaries, to the lymphatic vessels, so that we always keep fluid moving. We don't want stagnation of fluids, in the tissues. You want them moving, because when you have stagnation, and if there are microbes, or if you even have like something like diabetes mellitus, then you're going to create problems. Microbes can proliferate. They're not going to be forced through a system that will ultimately detect their presence by other white blood cells, and we can't initiate our immune system. Okay, so here I'm showing the capillary sphincters. Those are the round little muscular walls there, so they can control how much blood is entering that capillary bed. And here's a picture of the squamous cells. So because the squamous cell borders are not nice and flat and regular, they're kind of irregularish, then it has these kind of like a pore almost, a little open window, between each squamous cell, and that allows material to move into and out of that vessel. This is a great picture. All right, so here we have an arteriole capable of vasoconstriction dilation, branches off, and here we have the arterioles enter where we would have precapillary sphincters. You can see the arrows indicating the direction of blood flow, and the blood coming from the arteriole still has a good amount of pressure from the pressure generated from the left ventricle, pushing the blood out into circulation, right? So once that blood enters into the red side capillary bed, you see the little arrows coming out. That's saying, okay, here is where, due to the pressure of that water pump, so to speak, we are now able to, pump fluid and different molecules that can fit through the slit openings, little windows of the squamous cells. It's going to exit. So it says up here to the right in blue, fluid moves from through the interstitial space. So we're pushing stuff outward. As the blood crosses over to the blue side, now the blood acts like a hypertonic solution, and it draws some of that fluid and different molecules back in. All right. And then it recollects, the veins collect into venules and veins, and back to the right atrium we go. Right. Now over to the lower left-hand side, you see that green tube system there? That represents, a lymphatic capillary that will be part of your lymphatic system. And you see how you have black arrows entering into it? The lymphatic system is going to have negative pressure in it, like these capillaries. So it's sort of like, and I have crazy analogies, but when you use your vacuum cleaner, you create, again, there's a kind of a pump, so to speak, to suck, material into the opening at the hose. Well, capillary sphincters or lymphatic capillaries are similar to that. There's going to be negative pressure inside that vessel that, kind of sucks up some of that fluid. Thereby we lose, we push out fluid and molecules on the arterial side of the capillary bed. Some of that fluid, and a lot of it, gets drawn back into the venous side of the capillary, but that green lymphatic vessel is going to attempt to pick up kind of everything else. And so we have this flow outward, back inward, and circulatory pattern of the interstitial fluids here, so that we don't have stasis. We don't have any kind of, drop in, accumulation of fluids there. Everything is kind of moved, just like blood circulating around the body, going out the arterial side and returning in the venous side, if that makes sense to you. Okay, so the venules receive blood from the capillary beds. It's going to be deoxygenated blood. Venules form veins, and veins form to unite larger veins. As we get into the veins, we have, really the same, for all intents and purposes, there are the same 3 layers as the other arterial vessels had. You have a tunica externa, tunica media, tunica interna. In veins, that tunica externa is thicker than an artery. Okay. Has a larger lumen. That is important to understand. It helps you identify an artery versus a vein when you're looking at a slide histologically. And the muscular wall is going to be different. Veins are thinner and arteries are much thicker. Thus, veins have a larger because the lumens are larger in the veins, and because you have some extra veins than you do arteries, the venous side of circulation can store and will store more blood on the venous side than the arterial side. So when we circulate blood, and let's say we have our average 5 liters of blood, we don't find 2.5 liters on the arterial side and 2.5 liters on the venous side. It's more like a 60-40 split. Because the lumen of the arteries are narrower, they can only really accommodate 40% of what's circulating. The veins will hold around 60% because we have more veins and larger lumens. So the veins act as a volume reservoir, preserves and stores the volume. The arterioles act as pressure reservoirs because of those thick arterial walls. Blood under low pressure, so the blood is under lower pressure in the veins. The farther away you get from the left ventricle, the more the pressure in the vessels drop. Thus, especially with the vessels, veins carrying blood from the arms and the legs, you're going to have these one-way valves, just like we found, in the AV valves and the semilunar valves of the heart, because now you're trying to bring blood back with less pressure and against gravity. All right, so I'm going to show you is as muscles contract in the lower extremities, like your gastrocnemius, your soleus, as the veins pass through those regions and the muscles contract, they squeeze down on the veins. And when that happens, it creates pressure in that vessel. The blood wants to move, either upward or downward. Well, it won't drop downward so much because the valve behind that contraction point is not going to allow blood to fall down, so that when the muscle contracts, the blood has only one way to go, upward through the next valve. And when the muscle relaxes, the blood only falls back as far as the valve it just passed through. So it's similar to blood passing through from like the right atrium to the left ventricle. The right atrium to the right ventricle, and the left atrium to the left ventricle, and the ventricles out to their respective big vessels. Those valves prevent blood flow. When the ventricles contract, the valves between the artery, the aorta and the ventricles shut close, the tricuspids and the mitral, so that the blood has only one way to go, from the right ventricle into the pulmonary trunk and the left ventricle into the aorta. This is the same kind of phenomena. So this is one of the methods that we use to return venous blood kind of against gravity, back up toward the heart. Okay, blood location, as I mentioned before, keep in mind blood is not distributed 50-50. In reality, about 60% is going to be on the venous side and about 40% on the arterial side. Thus, we call them volume reservoirs. Okay, this pie wedge helps you understand that as well. Okay, hemodynamics. Remember, the cardiac output equals the total flow for 1 minute. How much blood is being injected by the ventricles for 1 minute? So cardiac output equals stroke volume times heart rate. And blood pressure equals cardiac output times resistance, or what we might refer to as peripheral resistance. Blood pressure can also be rewritten by substituting the two variables above. Blood pressure can and does equal stroke volume times heart rate times resistance. So what we're saying here, is that since we know that there are two variables associated with cardiac output, and we know algebraically, and I'll never give you a question where the variables are going in opposite directions. For instance, cardiac output. And if I said, hey, if stroke volume is decreasing, what's happening to cardiac output? It would decrease. If I asked you about heart rate, if it was increasing, then cardiac output would increase, right? I won't say, well, if stroke volume is dropping and heart rate is increasing, that would not be appropriate. But knowing that SV times HR times resistance equals blood pressure, I could ask you a question such as, well, if heart rate increases, what happens to blood pressure? It increases. If stroke volume increases, what happens to BP? It increases. And vice versa. Heart rate decreases, blood pressure decreases. If resistance increases, blood pressure increases, and so forth. Okay, so blood pressure is the force of blood exerted against the inner walls of a blood vessel. It's measured in millimeters of mercury. Arterial blood pressure rises when the ventricles contract and falls when they relax. Now, the maximum pressure, upon ventricular systole is the systolic pressure, and that's always the value in the numerator. The diastolic pressure in the denominator is the maximum pressure exerted when the ventricles are in diastole. So the systolic pressure is the maximum pressure exerted, and it's generally, average around 120 millimeters of mercury, and the minimum pressure exerted is generally around 80 millimeters of mercury. All right, so remember, when the ventricles relax and it's not ejecting any blood, the minimum pressure exerted on the vessel wall should not drop down to zero, because what would happen if the blood pressure dropped completely to zero? The blood would just completely stop moving. All right, so there's a high and a low. There's a range of maximum, minimum, which then maintains blood circulating in a forward direction. Pressure is greater at its source, the left ventricle, and diminishes the farther away we are from the heart. The pressure is low in the capillaries, about 40 down to 20 millimeters of mercury, and further drops in the veins, and further drops in the superior and inferior vena cavas, where it will be the lowest before it enters the right atrium. So here, this is kind of a handy dandy graph that indicates the pressure. So where we're maximal over to the left-hand side, this is in the aorta. All right, as it travels farther away to the arteries, to the arterioles, capillaries, the pressure significantly drops. And it's the lowest in the vena cava as it enters into the right atrium. I think that's a question somewhere. Ding, ding, ding. Okay, resistance. Resistance is the opposition to flow, is the amount of friction created when blood flows through or flows against vessel walls. It's just like when you roll like a ball or a tennis ball, across concrete or really any surface. Gravity pulls down on it. Those two surfaces, depending on the frictional coefficients there in physics, will eventually bring that ball to rest unless it's heading downhill. But we're saying if it's a flat horizontal surface. So anything that impedes blood flow, slows it down, is going to be considered resistance. So things like that are going to be the diameter of the blood vessel, all right? Major source of resistance. Arterioles are the major determinant of resistance because they have the ability to vasoconstrict and dilate, right? And those precapillary sphincters, right? So the more you constrict, the more resistance you, create, I should say. And thus blood pressure will go up. The less resistance, the more it vasodilates, blood pressure goes down. Blood viscosity, which we briefly talked about in the blood chapter. When the blood is thicker, it resists flow. Right? So when viscosity goes up, resistance goes up, blood pressure goes up, blood flow goes down, and vice versa. Total blood vessel length. The longer the vessel, the more resistance. If blood has to pass through a very short artery, there's less opportunity for friction to occur and the blood flow doesn't slow down much. There's less resistance, and, blood pressure would decrease. But if we have a long vessel, it's just that much farther, to have to push the blood through. There's more opportunity for the blood to, travel across the tunica interna, which is resisting the blood flow because it's stationary. And so resistance would increase and blood pressure would increase. Those are three major sources. All right, baroreceptors are a type of mechanoreceptor. Remember, we looked at all these different receptors in AMP1. Baroreceptors are kind of a type of mechanoreceptor, but I wouldn't call them a mechanoreceptor because most mechanoreceptors are going to respond, most of them, when you compress them or squish them, so to speak. But these receptors will respond when they're kind of stretched. Right? All right, so they are a type of receptor sensory neuron that is excited upon stretch of the blood vessel. they're located in particular areas. We talked about this briefly in the autonomic nervous system in AMP1. In the aortic arch is where we find the aortic bodies. And in the carotid arteries, we find about where the carotid arteries bifurcate into internal and external arteries. Just beyond that, just into the internal side, we have carotid bodies. And what we find at these body areas are two types of receptors. We have the baroreceptors and we have chemoreceptors. The baroreceptors there are responding to how much stretch is being exerted on the vessel wall when we're ejecting blood from the left ventricle. In the aorta, it's evaluating what is the pressure, or is it adequate or too high or too low, when we're pumping the blood out into systemic circulation. And those in the carotid arteries are, detecting and monitoring the appropriate pressure of blood that has to circulate up into the brain. Right, so both critical areas. We also have chemoreceptors there, and they're going to respond to the level of gases in blood, because that's also a good place to evaluate how well we gas exchanged at the lungs. Because from the lungs, we go to the left atrium, left ventricle, pump it out, and close to that source, we're like, okay, let's check to see, what the oxygen, carbon dioxide levels would be, right? All right, so depending on the force generated at those baroreceptors, we are able to adjust heart rate and blood pressure from there. So baroreceptors act immediately as part of a negative feedback system called the baroreflex. Remember, most feedbacks in our body are going to be negative. We start at one point, we end with the other. So what effect does standing up? All right, let me go back again. So when you are ejecting blood, let's say, and you are in parasympathetic mode, you're resting, so forth, and the blood is, the left ventricle is pumping blood at a regular pace. You're going to have a certain amount of signals being discharged from those baroreceptors that lets your brain know, okay, this is the current pressure. We have proper, from the chemoreceptors along the same pathway, it's properly oxygenated, and the pressure is good, not too high, not too low, just right. But, if you're exerting pressure and excess pressure or higher than normal pressure on the walls of those aortic bodies and the carotid bodies, and the baroreceptors are detecting higher pressure in the vessel there because the left ventricle is pumping harder and maybe more frequently when we don't want it to, then we're going to send signals to the brain to slow down the heart and drop the blood pressure back to normal. I could have probably said that more eloquently. Maybe I need another sip of Starbucks. All right, so when we start elevating our heart rate and force of contraction, the blood pressure is going to go up. And if it's higher than we want it to be, then we are going to attempt to drop the blood pressure. So the baroreceptors, when the pressure is going up, is going to send more signals to the brain. The response, will be described as follows. We're going to have a parasympathetic response and a sympathetic response. If the number of signals normally generated drops too low, then we're going to respond as well, because now we want to elevate blood pressure. So what the question down here is, what effect does standing up quickly have on the discharge of impulses from those baroreceptors? When you stand up quickly, gravity pulls on the blood and it drops downward, which means that the pressure in that, detected by that baroreceptor is going to drop. And it's going to send fewer signals to your brain, which your brain goes, up, now the blood pressure is dropping lower than what I want it to be. So the response will be to increase heart rate, and to vasoconstrict to increase the pressure in the system. Now, it might not do that for very long, but it will do that. So what effect will this have on blood pressure? Initially, your blood pressure drops. as a consequence of this reflex, the blood pressure will elevate. Which cranial nerves, oh, this is a good one. Which cranial nerve carries sensory impulses from the aortic body? Which from the carotid body? Right, so remember, anything below the shoulders is conveyed on vagus nerve, baby. So that would be vagus cranial nerve 10, and carotid arteries, or the carotid bodies there, would be glossopharyngeal cranial nerve 9. Okay, so that confirms here, this diagram here. Here are the carotid bodies, here's the aortic bodies, or cranial, vagus nerve versus glossopharyngeal. Okay, mean arterial pressure. Mean arterial pressure is the average pressure in a patient's arteries during one cardiac cycle. It is considered a better indicator of perfusion to vital organs than systolic blood pressure. Nursing school loves this. They love this stuff. MAP comes up all the time. So how might you calculate that? Mean arterial pressure equals systolic blood pressure, SBP, which is indicated down in the lower left-hand side. SBP equals systolic pressure. DBP equals diastolic pressure. So SBP plus 2 times the DBP, divided by 3. Or 1/3, in parentheses, systemic blood pressure minus diastolic blood pressure plus diastolic blood pressure again. All right. So you find the difference here in the parentheses. You're looking for the difference between systemic and diastolic pressure, right? Which will be a value. If it's 120/80, then the difference is 40, right? Plus, and then you add back in the diastolic and you divide it by 3. Either way, either one is utilized by them. A MAP of 60 millimeters of mercury or greater is believed to be needed to maintain adequate tissue perfusion. So that's kind of a good thing to keep in mind. I don't necessarily ask you that equation or anything, but for those of you going into nursing, they love this stuff. Okay, venous blood flow. Blood pressure decreases as the blood moves through the arterial system into the capillary bed, so forth and so on as described. We said it gets decreases and is the least amount in the vena cava. Blood flow is depending, venous blood flow, and I'll just tell you right now, lymphatic blood flow is dependent on this as well, because you're going to be moving lymphatic fluid from the legs and arms through the torso back to the subclavian veins similarly. So it depended on skeletal muscle contraction, and it shows you muscles here. Let's say these are gastrocnemius muscles. As venous blood is passing through that vein and the muscle contracts, it compresses the vein. All right. So over to the left, when we compress it, the blood squirts really up and down. But when it pushes it downward, it closes the valve so that the blood has only one way to go in a forward direction, upward, until the muscle relaxes. And then the blood that there is found there falls back down, and it'll close that vein. It will close the valve behind it. Right? So the same kind of dynamics moving blood from the ventricle into the blood vessels. It closes the valve behind it, so blood has only one direction to go. And it keeps milking like that all the way back up to essentially your subclavian veins. All right, breathing mechanism does that as well, especially in the abdomen and in the chest, because as you breathe in and out, and your diaphragm drops because your lungs are expanding, and even in the thoracic cavity, by doing so, it creates pressure on the vessels that are passing through there, the aorta as well as the inferior vena cava. Right? So that essentially has a compressive nature right in the thoracic cavity, keep pushing blood up toward, the right atrium. And in the abdominal cavity, that's why your abdomen rises when you take a breath in. And in doing so, it creates pressure within the abdominal pelvic cavity. And that compresses the veins that are passing through there, merging in the inferior vena cava and working its way back to the right atrium. Vasoconstriction helps. In these veins, as well as the lymphatic vessels, the walls are so narrow that it's never going to change the diameter significantly at all in the veins or the lymphatic vessels. But what it does do when it constricts is not allow it to balloon outward. You just don't want it to balloon outward and therefore, absorb some of the fluid that's trying to pass through there. You want the vessel walls to constrict to a certain point so that it doesn't, create like an aneurysm. The one-way valves, as described, veins and the lymphatic vessels had one-way valves. Right, so those are 4 important variables. This shows you again a muscle contracting. When it contracts and squeezes down on the vein, the blood, forces the valve behind it to close or to stay closed, and it pushes open the valve above it or distal to it. As that muscle relaxes, some of the blood falls back down, and boom, it closes the valve again. Okay, factors that influence arterial blood pressure. So here in the center, it's telling you, hey, these are the different factors that are going to increase blood pressure. And as we said before in the previous slide, you had that equation. You had cardiac output times peripheral resistance. But remember, you can also rewrite cardiac output as stroke volume and heart rate, right? Okay. So this is where it kind of breaks it down. So all 5 of these things can contribute to increasing blood pressure. If we increase blood volume, the more fluid we have in this limited system, the more it exerts its pressure on the vessel wall. Heart rate, you increase heart rate, you increase blood pressure. And stroke volume, all right? That's all part of cardiac output. Down below, we're talking about resistance factors. Peripheral resistance increases, like vasoconstriction, that'll increase blood pressure, and precapillary sphincters, yep, that'll do it. And the viscosity of the blood, we said, the thicker the blood, the more it slows down blood flow, it increases resistance. That's part of the resistance variable, and as viscosity increases, blood pressure increases. Right, this, determine, or this is the 2 pathways that sympathetic and parasympathetic systems use to address, the changes that you need to physiologically make when you have changes to blood pressure, that are either as a consequence of the variables listed above in the previous slide here, and or the discharge from those baroreceptors, because that's a direct indication of what's currently occurring, at the different baroreceptor locations in the chest and the carotid arteries. Okay, so let's say over here to the left, we're going to have a parasympathetic response and a sympathetic response. And I do like to ask these things, right? If cardiac output increases, all right, then blood pressure increases. All right, now, as a consequence of that, the baroreceptors in those locations are stimulated and they start sending more impulses to the cardiac center, in the medulla oblongata and in the brain. The parasympathetic response is going to carry impulses to the heart. And remember, when we excite the parasympathetic division, we depress heart rate. So we are going to, inhibit the SA node with the acetylcholine that parasympathetic releases, and it decreases your heart rate. And when heart rate decreases, blood pressure decreases. And the goal is to decrease the blood pressure back to a normal range. So when we stimulate the parasympathetic division, we decrease heart rate, decrease blood pressure. Over on the other side, it's similar, the origin. Rising blood pressure stimulates the baroreceptors. Now we send impulses to, technically the vasomotor center. But the point is that the brain then detects that. And now what is it going to do? How is the sympathetic system going to adjust or try to remedy this? Is that we will have fewer signals, before we sent more signals in the parasympathetic. In the sympathetic system, we're going to take our foot kind of off the gas, off the accelerator, so to speak, and we're going to send fewer signals down to the arterioles. And when that happens, just like in the bronchodilation and things, it allows those smooth muscles to relax some, not completely. You don't want them to relax entirely, but you take the foot off the accelerator and let your car slow down some without stopping completely, and it allows those arterioles to dilate. That decreases the peripheral resistance and thus decreases blood pressure. So we address heart rate through the parasympathetic division and vasodilation through this sympathetic nervous system. Remember, the sympathetic nervous system and the autonomic nervous system, is the sympathetic tone we talk about to blood vessels. The sympathetic system is really what's going to control on an autonomic basis the degree of vasoconstriction and dilation. The parasympathetic dominates heart rate by generally slowing it down, because otherwise it beats about 100 beats per minute from the SA node. All right. So the parasympathetic is controlling the heart primarily. The sympathetic division is controlling vasoconstriction and dilation. Now, as we know, without belaboring it, sympathetic system can override the parasympathetic when you're in the fight or flight mode. But, we're talking about here, when you're not in sympathetic mode. How am I going to be adjusting blood pressure, from the stimuli I'm receiving, the feedback I'm receiving from the baroreceptors? And that's how it's accomplished. Blood pressure regulation. And I'll just tell you, blood pressure, is influenced by, complicated wise, 3 different areas. But these systems all, work together. Remember, the vasomotor tone to the heart is primarily controlled by the vagus nerve, because it slows it down, and under sympathetic stimulation, it can override, of course. Altering blood volume, increasing or is going to affect blood pressure. If we increase blood volume, we increase blood pressure. We decrease blood volume, we decrease blood pressure. So there are 3 methods of change: neuronal changes, hormonal changes, and autoregulation. Okay, so neuroregulation. The vasomotor center in the medulla oblongata regulates blood pressure by changing the arterial diameter using the sympathetic nervous system, as I just described. We have the baroreceptors and the chemoreceptors in those aortic and carotid body areas. And the baroreceptors respond to the changes in pressure, often postural changes and things like that, activity. Chemoreceptors respond to changes in oxygen levels or pH. Again, so we're monitoring pressure and appropriate oxygenation, of blood as we circulate to peripherally as well as to the brain. Hypothalamus also regulates in response to fight or flight, initiating the sympathetic nervous system. All right, so you can kind of look at this on your own, but it describes the responses I just talked about in back here. It puts it to a diagram. Okay, so here we have homeostasis of blood pressure on the seesaw there. And it shows you, well, when the imbalance is such that blood pressure over here in number 1, the stimulus is increase in blood pressure. Baroreceptors detect that, send signals to, the medulla oblongata. What is the response? Parasympathetically, we slow down the heart. And sympathetically, we allow the smooth muscle arterioles to dilate, and we decrease blood pressure. Here over in 4A, they're saying you're going to decrease the sympathetic impulses to the heart. That depends, on what autonomic nervous, what portion of the autonomic nervous system we are in. If we're in sympathetic mode versus just changes like I described before, standing up, that's not sympathetic mode, so this chart here is what you want to go by. We will slow down heart rate by stimulating the parasympathetic division. And then down below, it's going to describe the opposite. So you can kind of read on your own. Okay, hormonal regulation, because we kind of need to get through this. Short-term regulation, remember that we have hormones when we talked about, well, actually, I take that back. We talked briefly when we talked about, blood and things, about different hormones that will act on blood volume and therefore blood pressure. I believe we talked about it in there. We have the different hormones that we'll talk about more extensively when we get into the endocrine system, that help regulate blood volume and blood pressure. They act on the kidneys as well as other areas. But, as per our discussion, the autonomic nervous system and sympathetic stimulation, we use the adrenal medulla to release epinephrine and norepinephrine as hormones into the bloodstream to increase heart rate, to vasoconstrict, increase blood pressure, and so forth. Right? All the physiological things that need to occur when you are in sympathetic mode. So that is one source, right? Those are hormones. When we secrete compounds into the blood and we circulate it, we call those hormones. So when we do stimulate the fight or flight mechanism, we not only send impulses down the neurons to release norepinephrine, but we use the adrenal medulla to secrete epinephrine and norepinephrine in the blood. And that way we can target all these different tissues very quickly, and bind to either the alpha 1s, alpha 2s, or the beta 1, beta 2, beta 3 receptors. And the response always when we're in sympathetic mode is to increase heart rate. You're going to increase cardiac output as well. You're going to vasoconstrict and try to, all over the body somewhat increase blood pressure. So that's one way, right? Because we said heart rate and cardiac output and vasoconstriction all increase blood pressure. Right? We're also going to use what's called the renin-angiotensin system. And we will, again, detail that a little bit later. But when we do that, we ultimately produce what's called angiotensin 2. And angiotensin 2 is the active form of angiotensin 1 and angiotensinogen that promotes this further secretion of antidiuretic and aldosterone hormones. And both of those act on the kidney one way or the other, right, to absorb more water and to increase blood pressure. Angiotensin 2, unlike ADH and aldosterone, can also, in a different way, is increase vasoconstriction kind of systemically all over the body, kind of like how epinephrine and norepinephrine did in a way, to increase blood pressure. So all those increase blood pressure. Right? Now, one hormone that decreases blood pressure, and we will come back to it, is atrial natriuretic peptide. When our blood pressure is higher than normal, then we're going to release ANP, and that decreases blood volume overall. And right now, that's really all you need to know. Decrease blood volume, decrease blood pressure, but it does so by increasing sodium and water secretion into urine where you're forming urine, and allows more fluid to overflow through the kidneys to the bladder, and now decrease the overall volume of fluid in the body and decrease blood pressure. Antidiuretic from the post-pituitary is going to target the kidneys to reabsorb water as well. So as we reabsorb water where we're producing urine, it enters back in the cardiovascular system and thus increases blood pressure. Okay, so hormonal regulation, blood volume and blood pressure. Here are the hormones. The first three are released when we have volume or pressure that is lower than normal, and ANP is secreted when the blood pressure or volume is higher than normal. I indicated them in red or blue, right? So when volume or pressure is low, the three hormones here in red are going to elevate blood pressure. So the stimulus for their release is going to be low blood pressure or low blood volume, or maybe a change to, the amount of sodium chloride, present, but for all intents and purposes, it's when the volume or the pressure is low. And the only one that we use really when we have higher than normal blood pressure or volume is the blue atrial natriuretic peptide. So how do they basically work? Antidiuretic targets the kidneys and stimulates the thirst center in the brain so that you start drinking some more fluid. Targets the kidneys to open up those aquaporins. So remember, those are pores that are for water only to pass through. And in these repeating tubules in the kidneys that we call nephrons is where we form urine. If I open up that faucet, the water will flow. It will diffuse and flow where it's in higher concentration in this closed tube system, into the interstitial space and back to blood where it's in lower concentration. Aldosterone works a little bit in a more complicated manner, right? And by the way, antidiuretic is the one you're going to use most and primarily, and it's really, really effective in absorbing the most amount of water that you want to absorb. But if that's not getting the job done, then we're going to take kind of like more extreme measures, and we release aldosterone. And aldosterone comes from the adrenal cortex. Adrenal medulla is the inner region, epinephrine and norepinephrine. Adrenal cortex, we have 3 hormones from there. But aldosterone from that area targets the kidneys, but it acts in a different way. It's going to actively pump sodium from inside of one of those little tubules that are called nephrons. It's going to actively pump it from inside that tubule into the interstitial space. And where sodium goes, what follows? Chloride, right? And where salt goes, what follows? Water. They use this analogy a lot in nursing as well. Where salt goes, water goes. Where salt goes, water goes. Where you are creating a hypertonic solution, essentially, it's going to draw water osmotically to it. All right. However, using aldosterone comes at a cost. For every sodium I absorb, I'm going to have to secrete and lose a potassium into urine, or the filtrate that becomes urine. Okay. So I actively absorb and pump, which takes ATP, sodium, chloride follows it, water follows it. I secrete a potassium, and now that water enters into the cardiovascular system and increases blood pressure. The renin-angiotensin system is even more complicated. And we come back to this, at least 2 more times, right? If blood volume or BP are low, what's called the JG cells, the juxtaglomerular cells found within what's called the afferent arteriole, which is an arteriole that supplies one of these nephrons that forms your urine in the kidneys, secretes renin. So we're going to look at that anatomy when we get to kidneys. But just to be said, in the kidneys itself, right, there will be these cells that secrete renin. And renin is kind of an enzyme hormone, so to speak. So renin has to be present. When the blood pressure is low, renin will be secreted. And because these cells are in an arteriole, it's going to go right into the blood, right? It's in the walls of this arteriole. So it goes right into the blood, kind of like a hormone. Right. That renin is going to circulate, and it's going to come across an inactive molecule called angiotensinogen there in black. When they end in OGEN, it means a molecule like this is constantly being produced, but it's inactive. It's kind of like converting vitamin D to calcitriol. You have to have parathyroid hormone present. So this angiotensinogen is available when necessary. So when it's necessary, the renin is going to convert angiotensinogen to angiotensin 1. Still inactive. Now we need to convert angiotensin 1 to angiotensin 2. And when the blood circulates to the lung, through the lungs, that's where we're going to have the conversion of angiotensin 1 to angiotensin 2 by what's called ACE, angiotensin converting enzyme. Maybe you've heard of ACE inhibitors. When blood pressure is high in a patient, we might try ACE inhibitor. We're going to help inhibit the conversion of angiotensin 1 to angiotensin 2, because angiotensin 2 is a powerful compound. Right. So if we don't secrete ACE, then we won't be producing it. We will be stopping at angiotensin 1, essentially. But when we do produce angiotensin 2, what does it do? It increases antidiuretic hormone secretion. It really secretes aldosterone. Again, further stimulates the thirst center. So maybe you really now's the time to really start taking in a lot of fluid. And it causes vasoconstriction of arterioles to increase blood pressure. So it's this renin-angiotensin system. Unlike antidiuretic and aldosterone alone, they will not stimulate vasoconstriction of arterioles. But now things are getting kind of dire. So we really need to increase the blood pressure systemically, because we have to keep circulating blood appropriately to the brain, through the kidneys, and so forth, and all around the body. So this renin-angiotensin system, and angiotensin 2 is a potent vasoconstriction of arterioles to increase blood pressure. This shows you, I like this picture, how angiotensinogen is always kind of constantly being produced by the liver. When needed, the kidney secretes renin, which acts as the enzyme to convert angiotensinogen to angiotensin 1 down in the blood vessel. It circulates through the lungs. The lungs are going to be releasing ACE, kind of all the time. And if there's no substrate like angiotensin 1, it's no big deal. But when you do have angiotensin 1, that ACE will convert it to angiotensin 2. And thus, below in the green arrow, vasoconstrict, increased aldosterone secretion, increased thirst, increased antidiuretic. Okay, atrial natriuretic peptide in blue, produced by cells in the heart, in the atria of the heart in response to stretch, because now it's saying, wow, we're really stretching more than we should. We must have a higher volume and pressure in here than we really need. Stimulated by high blood pressure and blood volume. It inhibits secretion of antidiuretic, aldosterone, and renin, the previous three. And once we shut those off, the current amount of fluid in blood, in plasma, is eventually going to circulate through the kidneys. And if we don't secrete those first three hormones, we will just kind of let the excessive fluid that we have in the system pass through the kidneys, produce more urine, let it flow down to the bladder, and eliminate from the body. All right, so AMP will decrease blood volume and blood pressure. Remember, blood pressure is mainly under the control of the sympathetic nervous system. This is important. I'll make a whole separate slide for this. Always maintaining some degree of muscle contraction of the tunica media, thus riding the accelerator of a car, so to speak, all the time. You never want your arterioles or your blood vessels to totally relax, because what would happen as blood is being pushed through there with the hydrostatic pressure, it will balloon out and you'd have an aneurysm and you'd just bleed out. Right? So there's always a certain amount of accelerate, your foot on the pedal to keep your car moving all the time. You don't want it to come to a complete stop, and you don't want to go too fast that you get a speeding ticket, right? So you can adjust that accelerator. You can control how many impulses travel down to the arterioles. The more signals you send, the more vasoconstriction you produce, and the more high blood pressure is then produced. If we decrease the impulses going down to the arterioles, the more the smooth muscle relaxes, it dilates, we decrease blood pressure. Heart rate is mainly on the parasympathetic control. We're always riding the brake on the heart. Again, you have intrinsic, the heart is autorhythmic. We have different sources of heart rates that are generated from the SA node, the MVAV node, and the Purkinje fibers. And on the most part, you're at rest or doing things. You don't need your heart bumping 100 beats per minute. So the parasympathetic division is stimulated and secreting acetylcholine so that you slow down heart rate, conserve energy. Blood pressure, sympathetic control, greater or lesser amounts of stimuli to the blood vessels to either allow them to dilate or constrict. Increased blood pressure, decreased blood pressure, and so forth. Heart rate is controlled by the sympathetic division. When needed, the sympathetic division will override the parasympathetic, of course, when you're in fight or flight mode. Monitoring circulatory efficiency. Well, we have pulses. Pulses can be monitored wherever blood, arteries come up to the surface of the body, especially at joints, in the armpit, in the bend of the elbow, at the wrist, behind the knee, in your femoral acetabulum, in the hip, to the anterior aspect, of your thigh. So pulses are created by expansion and constriction of elastic arteries during cardiac cycle. Blood pressure is the measurement of the blood exerted against the blood vessel walls as they pass through these different arteries. One of the easiest places to measure your blood pressure is using your sphygmomanometer, your blood pressure cuff, around your biceps brachii above the elbow joint. It measures the pressure exerted against the blood vessel wall in millimeters of mercury. Normal blood pressure is about 120/80, systolic over diastolic pressures. Hypotension means below systolic pressure below 100 millimeters of mercury. And hypertension is generally, and this is kind of arguable, when your blood pressure exceeds 140 over 90. Usually this can be controlled by diet and exercise and drugs and things. Now I will tell you that, they are changing those guidelines, and they kind of go back and forth. And some books will tell you, it depends. If the systolic is over 140, but your diastolic is around 80, less than 90, they're just like, okay, that may constitute, hypertension. It doesn't have to be both systolic or diastolic pressures that need to be higher than normal to, term this hypertension. And in the same respects, you could be about 125 systolically, but your diastolic is 90 or 95. Some sources consider that to be hypertension. Now they're saying, well, if you are even 130 over 85 or 88, it's hypertension. I think that's going above and beyond, just so you can maybe, put people on hypertensive medications, but it does warrant monitoring on a regular basis. Sometimes people are just rushed. They drink too much coffee. You take your blood pressure, and you should be doing it really with a sphygmomanometer and your stethoscope. It's really the best way to determine really what the blood pressure is. Some of those that are, you just wrap around the wrist, you have to be very careful that you are using that appropriately, because the wrist really should be level with the heart. And it's very easy, if the arm is hanging down, for that, the one that you wrap around your wrist, is to detect higher than normal pressure. Because of course, if your arm is hanging down, you ever notice the veins pop out on your arms more? They do on mine. I'm much older than you guys. So there's more pressure in those vessels. So there's an appropriate way to use those auto ones. The ones in the hospitals on the wall, on the walls, are generally good. But for, these really do need to be tested periodically, make sure that, they're working in normal ranges, and you're not, detecting high blood pressure when it's it's really not high, or low blood pressure when it's really not low. You want to make sure that these methods, whatever methods you're using, become calibrated now and then and tested to make sure, that they're detecting highs appropriately, low pressures, and normal pressures. These are an indication of different areas where you can feel pulses. Might not necessarily be an area where you're going to take a blood pressure, but you can definitely find pulses. And especially when you have trauma to a patient, dislocation of a joint, fracture of a bone that's being realigned, is that you want to make sure that distal to the point of that fracture, that laceration, that relocated joint, that you can feel pulses in those extremities and areas. Because by relocating a joint and so forth, is that you might have somehow not you necessarily, is that vessel became compromised, and obstructed or compressed. If you can't feel pulses distal to the point of that, fracture that you repaired, or the joint that you relocated, or you're putting pressure on that laceration, that you need to know that there's blood flow to these proper areas. If there's no blood flow, then there's no oxygen and nutrients, and the tissue is going to die. Okay, circulatory pathways. We have the pulmonary circulation, the systemic circulation, the coronary circulation. And this was somewhat covered in the cardiac chapter. Pulmonary circulation is the heart to the lungs, back to the heart. Systemic is from the heart to the tissues to the heart. And coronary circulation is, from the aorta, which is outside, to the heart and back to the heart, to the right atrium. All right, so pulmonary circulation, we start in the right ventricle. This is in blue because, we have deoxygenated blood, travels through the pulmonary trunk to the right and left pulmonary arteries. We go to the lungs, we gas exchange. We come back, as you know, as the right and left pulmonary veins to the left atrium. Right, that we kind of learned, at least the anatomy-wise, when we studied the heart. Only these are, and I have some stars here, these are the only arteries that carry deoxygenated blood, and these are the only veins carrying oxygenated blood. And I will say, like for men, For women, if you are pregnant and you have carrying a fetus, then the fetal circulation is going to be like this as well. Arteries will be blue and veins will be red. But, for all intents and purposes right now, these are the only arteries and veins that, don't follow the rule that arteries are red and veins are blue. Okay, here we're looking back to our friend of the heart. So blood returns through the three sources: superior vena cava, inferior vena cava, coronary sinus to the right atrium, right, down to the right ventricle, pump, via the arteries that are blue here, out to the lungs, gas exchange, come back. Okay. Systemic circulation includes all those following the branches that we looked at on the aortic arch when we looked at the heart. We have the aorta, the ascending aorta, which becomes the arch. Remember, the first branches off the aorta are the right and left coronary arteries supplying the heart itself. But then we have the three nubs, I call them, on the aortic arch, when we look at the heart models. And we have the brachiocephalic artery, the left common carotid, and the left subclavian arteries. The brachiocephalic artery travels over to the right side of the chest to give off branches. The right subclavian artery that's going to transport blood ultimately out to the right arm, and the right common carotid artery that's going to travel to the right side of the neck and give off branches. The next branch after the brachiocephalic, and by the way, we have one brachiocephalic artery, but two brachiocephalic veins. The left common carotid is the next vessel, on the aortic arch that's going to supply the left side of the head. The left subclavian artery becomes the blood supply to the left arm. The aorta then descends through the thoracic cavity as the thoracic aorta, and after it pierces the diaphragm, it continues through the abdomen as the abdominal aorta. So we can here follow the aortic arch. We have the brachiocephalic artery, where it's going to transport blood from the heart, which is on the left side of the body, over to the right side, and then it will give off a right common carotid artery, a right subclavian artery, goes under the clavicle. That vessel will then pass through the armpit as the axillary artery, along the humerus as the brachial artery, and then it's going to bifurcate in the forearm into the right ulnar artery and the right radial artery. And that's where we stop. The left side on the aortic arch, that follows the brachiocephalic artery and describes the blood flow to the right arm. The left common carotid supplies the left side of the neck and the head. The left subclavian vein, just like the right subclavian vein, is going to then continue as the axillary artery, brachial artery, and the ulnar and radial arteries. All right, so here we can follow those diagrams, and you can kind of follow that on your own: axillary, brachial, radial, and radial and ulnar. Right, organ circulation, as the descending aorta becomes the thoracic aorta, and then the abdominal aorta passes through the diaphragm, and now we have the abdominal aorta, large vessel, left-hand side. Right, it gives off the first branching network off the abdominal aorta is what's called the celiac trunk, and it divides then into, and that gives off these three branches. A gastric artery that goes to the stomach, a splenic artery that goes to the spleen and ultimately the pancreas, and a hepatic artery that goes to the liver. Then that big vessel travels further inferior. You're going to have blood vessels that are called the mesenteric arteries. And you have a superior mesenteric and an inferior mesenteric toward the bottom, not the bottom, but more inferior aspect of the aorta. And these two branches come together to form this arterial network that's going to sit on top of your small intestine and large intestine. Because, those are like these long, like the small intestine anyways, narrow diameter, long hose. So you have to have a blood supply to all the kinks and regions of the small intestine and large intestine. So you're going to kind of looks like a very large capillary bed. So one of the next vessels called the superior mesenteric artery, and then below the renal arteries is going to be the inferior mesenteric artery, and they're going to form, it looks like a very large capillary bed that sits on top of the intestines. I don't ask you those, but that's what those are. After the superior mesenteric, we have the renal arteries, a right and left for each right and left kidney. Then it travels a little bit farther. It will give off that inferior mesenteric. And then it continues about, to about the umbilicus, a little below that, and it's going to divide into iliac arteries. Those ultimately give off branches that supply the organs in the lower part of the abdominal pelvic cavity, and then continue to be the arteries of the legs. So here in the abdomen, we see the aorta pass through the diaphragm, gives off what's called the celiac trunk. We have a hepatic artery. We have the splenic artery, and we have gastric arteries. That's really all you need to know. Right? And it's going to form networks, arterial supply to those organs. All right. Below the stomach there, you see that superior mesenteric artery. That's what I was referring to. Okay. So from the abdominal aorta, we have, and after we've given off these particular branches, okay, we're going to go down to the bottom here where it says the abdominal aorta. All right. And we're going to follow it. You're going to give off, now it's going to bifurcate into a right and left common iliac artery. When it says common, it means it's going to further branch. And that common iliac artery is actually going to divide into an internal and external iliac artery. The internal ones supply a lot of the organs in the lower part of the pelvic cavity, but we're not so concerned with that. So, but the major one, is going to continue as the femoral arteries because they, thus named because they parallel the femur. And they pass through what's called the popliteal fossa, which is behind the knee, in the popliteal fossa as the popliteal artery. And then it's going to travel about to the head of the fibula and branch again to an anterior and posterior tibial artery. The anterior tibial artery that's, coursing to the anterior aspect of your shin, is going to continue on the up, what's called the dorsal surface of your foot, right, as the dorsalis pedis artery. The posterior tibial artery that's passing through your calf muscles and things is going to descend toward your calcaneus and wrap around your medial malleolus. And that's your posterior tibial artery. And those are all pulse points, the posterior tibial artery and the dorsalis pedis arteries. So we go out as, this iliac artery, common iliac artery. It gives off the branches that's going to supply the legs, femoral artery to the popliteal artery to the anterior and posterior tibial arteries. And the anterior tibial artery continues as the dorsalis pedis artery. So let's look at that. Here we have, it shows you up here on the top, you have the abdominal aorta showing you the right side. We have this common iliac artery. And you see those two branches, that smaller one, that's the internal branch versus the external branch, which is much larger diameter. It passes under what's called the inguinal ligament. It now parallels the femur as the femoral artery. It pierces, a connective tissue here, one of your adductor muscles, and travels to the back of the knee as the popliteal artery, a pulse area. Then it's going to split here just below the femoral, the fibular head, so to speak, and it's going to give off an anterior tibial artery and a posterior tibial. Anterior tibial in the brighter red, right, continues as dorsalis pedis. Just keep in mind, I know it gets a little confusing, but as vessels pass through regions of anatomy, the vessel is usually named for the region it's passing through. So when it passes, and it's parallel in the femur, it's called the femoral artery. When it passes through the popliteal fossa, it's the popliteal artery, and so forth. Okay, so then we can see this whole branching network. All right, systemic veins. The superior vena cava drains blood from the head and neck and the upper extremities, and they travel back into the chest via brachiocephalic veins, or right and left. All right, so now instead of going from the heart and working our way out, with arrows kind of indicating the direction of blood flow away from the heart, now we have to look at the way it returns. So now in these blue vessels, you're going to have arrows, kind of pointing back toward the heart. All right, so the superior vena cava, inferior vena cava, remember, transports blood to the right atrium. The superior vena cava is formed by the right and left brachiocephalic veins merging. Yeah, the brachiocephalic veins are kind of a continuation of the subclavian veins. Subclavian vein and the jugular veins merge to form the brachiocephalic veins. All right, so then they form the superior vena cava in this case. And the inferior vena cava, is the big, large diameter blue vessel in the abdominal pelvic cavity that is receiving veins from all the other organs, is formed by the big veins from the legs. It's formed by or carries blood from the kidneys, from the liver. They're all going to jump into the inferior vena cava and work their way back to the right atrium. All right. So here we can see, most of the veins of the body. Let's start up at the head. The veins of the head will ultimately merge, into the jugular veins. The veins in the arm, there are smaller veins associated there, all right, but we don't have to know all of them. You're going to have your radial vein, your ulnar veins are ultimately going to merge into your brachial vein. There are a couple, when I said, there are more veins than there are arteries, and this is an example of that. Kind of bridging here in the elbow between the radial side to the ulnar side is what's called the median cubital vein. Over here, it shows it really in more detail in the left arm. This is where you do a lot of venipuncture. You can go to the middle of the elbow and over to the right, but you generally don't go immediately because there's nerves and things passing through there. You might use some of the veins in the forearm and the hand. But those veins, we just work our way back. A radial and the ulnar, and then your median cubital, will merge to form your brachial vein. You do have what's called a cephalic vein out here, but we're going to follow the brachial vein. Then you go from the brachial to the axillary vein, just like the arteries. We're just working backwards. The subclavian vein. The subclavian vein merges with the jugular vein to form the brachiocephalic veins. And those two veins form the superior vena cava. From the lower extremities, we're going to kind of work our way back as well. We have the dorsal venous arch, which is essentially kind of parallels that dorsalis pedis. We are going to have anterior and posterior tibial veins. We're also going to have an extra vein here, an important one, the great saphenous vein, that runs very superficially to the inside of the thighs. See how they start kind of down here with the dorsal arches, the dorsal venous arches, and they run parallel here in the inner part of the thigh, all the way up to where it's going to merge with the femoral vein. So the anterior and posterior tibial veins become the popliteal vein, which comes the femoral vein. That great saphenous vein medially, and there is a lesser saphenous out laterally, but we're not too concerned about that. The great saphenous kind of merges with the femoral vein to form that iliac vein. And now they're passing again under the hip joint here, the inguinal ligament, as the right and left respectively iliac veins. They merge to form the inferior vena cava. Connecting to the inferior vena cava are going to be the veins from the kidneys. The veins from the organs, the digestive organs, are not going to directly pump blood or transport blood into the inferior vena cava. Before they do that, they're actually going to merge and penetrate the inferior aspect of the liver as the hepatic portal vein, right? So it's kind of, anyways, I'll come back to a portal system when we get to the endocrine system later. But in any event, the veins from the digestive organs are going to merge to form what's called the hepatic portal vein. And it's going to penetrate along with the hepatic artery, the liver on the inferior aspect. And it's going to allow all the blood that's transporting nutrients and things from your digestive organs to the liver, so it has first dibs on what's being transported in that venous blood, like all these different nutrients. And it's going to take whatever it wants, and then from after the liver is done, a vein will form called the hepatic vein, and it's that will transport all that venous blood into the inferior vena cava and back to the right atrium you go. So here we have from, let's say, from the arms over here to the lower left-hand side, ulnar vein, and the radial vein, the right to the right, and the median cubital vein are going to transport blood to the brachial vein, axillary, subclavian. Subclavian and the jugular merge to form the brachiocephalic vein, and along with the same source of veins from the left-hand side, the left brachiocephalic vein and right brachiocephalic vein merge to form the superior vena cava. All right, then when we look, see, so here, right radial, let's say the radial, the ulnar, the median cubital, the brachial vein to the axial, subclavian and so forth. Did I have that in there? Yes, I did have axillary. All right, here's that median cubital vein. That gets used a lot for venipuncture. Okay, when it comes from the lower, or regarding the lower extremities, right and left, the same. Right anterior and posterior tibial veins, to the popliteal vein, to the femoral vein. About the level of superior aspect of femoral vein, those great saphenous are going to merge, right, and form the common iliac veins. Then the iliacs form the inferior vena cava. The renal veins, right and left from the kidneys, will directly, connect to the inferior vena cava, and that the other veins from all the other organs will merge to form what's called the hepatic portal vein. I'll show you in just a minute. All right, so this just shows you the same flow here. Shows you that smaller saphenous vein of not great importance, but the great saphenous vein, it gets referred to back a lot in nursing. So here I'm describing the hepatic portal system. The hepatic portal system drains digestive organs, the spleen and the pancreas, the intestines, and so forth. Though all the veins from those particular, like the superior, inferior mesenteric veins, the pancreatic vein, the splenic vein, the gastric veins, all those veins are going to merge to form one blue vein that delivers blood to the liver first for processing. That's called a hepatic portal vein. After the blood circulates through the liver, then leaving the liver to the superior medial aspect will be the hepatic vein. Hepatic portal vein is formed by veins of the digestive organs and enters an inferior aspect where you're going to see on the models the gallbladder. And the hepatic artery is going to be accompanying it. So you're going to see a red vessel, blue vessel, and the green vessel that's part of the biliary tree, it's called. Leaving after the blood circulates to the liver, it recollects into the hepatic vein. And that's what connects to the inferior vena cava and back to the right atrium you go. So here's a picture of those. These are all those different mesenteric veins. We have the veins from the other digestive organs, all merge to form the hepatic portal vein. Right? Enters the liver here, and then is going to recollect up above to the superior medial aspect as the hepatic vein. And then it dumps into or connects to the inferior vena cava. Okay, so that is the end of the lecture. Sorry, I kind of go a little bit quickly, but otherwise, you will be looking at a lot of these in lab and things, so not to worry. All right. I don't ask you a lot of sequence of blood going from one vessel to another, but occasionally I do. And of those that I do, they're generally ones that are reinforced in lab as well. Okay, so good luck. I'm going to end this video, and we will continue with lymphatic immune systems.